Still auspicious day. So today is Guru Purnima. So for NMO and for whole of Bharat, this is a very auspicious day occasion. So this we have this Teachers' Day on September 5th. We all know birthday of Dr. Radhakrishnan, the great philosopher. But Guru Purnima is the birthday of sage Vyasa, who gave us not he didn't write the Vedas, தொகுத்து வழங்கினார். ஸோ தொகுத்துறதுனால அவர் பேர் வந்துட்டு வியாச அப்படின்னு சொல்லிட்டு பேரு. ஸோ he is born to a fisherman woman, and then he gave all the four நம்ம இன்னைக்கு இருக்க ஜென்ரேஷன்ல இவ்வளவுதான் முடியும்னு சொல்லிட்டு நிறைய இருக்கிறத கொஞ்சமா 4 வேதங்களை தொகுத்து கொடுத்தார். ஆல்சோ he gave the Mahabharata, and so whole Indians we are Guru Parampara வழிபடுறவங்க எல்லாருமே we celebrate all our gurus on this auspicious occasion. So Dr. Priyathersini, happy Guru Purnima. Salutations, the holy feet of all our gurus and sages, all our teachers. So to introduce Dr. Priyathersini, she is UG and PG from Madras Medical College, and she is my immediate senior also at MMC. So happy to have you here. And she is now Associate Professor of Pathology at Ramachandra Medical College. On to you. Who will chant the NMO mantra? Kavita is here, or I'll do?
No, ma'am. Kavita is not there, ma'am.
Okay, so we'll do the NMO mantra and start the session. We'll chant Om thrice. न त्वहं कामये राज्यं न स्वर्गं न पुनर्भवं कामये दुःखतप्तानां प्राणिनां आर्तिनाशनम्. So all doctors on this day we will vow to take away, to remove all the difficulties, illness of human beings. We'll try to remove them as much as possible. That's the whole crux of this NMO mantra. So on to you, Dr. Priyathersini. Thank you.
Thank you, Vani, for the opportunity given. Good evening, everyone. Hope I'm audible to all. Can hear me, right? Wait a minute, I'm not able to change the slides. 1 second. Yeah, it's coming. Okay. One or two people, can you please reply when I ask a question so that I'll know I'm not talking to an empty screen?
Yes, ma'am.
Okay. Okay. So you're all busy preparing for your exams, and this is just going to be a small pointers towards writing your essays and short notes. You have been taught all these topics already. So the entire systemic pathology, one half you're going to see today within an hour, and the other half will be next dealt in the by another faculty. Okay. So starting with systemic pathology part 1, these are the chapters I'll be dealing, like blood vessels and heart, lung, oral cavity, GIT, liver, biliary tract, and pancreas. So I can assure you that one essay question is going to come from any of these 6 topics. That is the case mostly. So, and you can get case-based questions in these topics a lot. Okay. So some of the common, I have divided chapter wise so that it's easy for you to keep in mind and also not miss anything. And few questions, few topics, most of the topics I've put few important slides so that we can discuss that. Is that fine? Okay, we'll start with the blood vessels. The first 2 important essay questions that usually come in blood vessels topic is, one is atherosclerosis, the other is hypertension. And other short notes mostly is aneurysms, coarctation of aorta, all your vasculitis, everything comes as a short notes. But a few years, the vasculitis per se has come as an essay question also, but it is not that common. Okay. So just be prepared for the eventuality. And throughout in our medical papers everywhere, essays and short notes are always interchangeable. So just don't get panicked when you see an essay question, short note question and an essay. You just write what you know clearly. It is enough. You don't count the number of papers when we correct. We are going to see for the keywords. If you have written, you will get the marks. Got it? Okay. Starting with atherosclerosis. So this is something very commonly asked question. And what you have to start, this is my brief pointers to write any question. In systemic pathology per se, if any topic is asked, start with an epidemiological data. Say it is what is the general incidence, what is the sex incidence, what is the race incidence, and what is the age group you commonly come across, what is the common symptoms you see, all those things. If at all, if any tumor you are associated any molecular in the mode of inheritance or molecular anomaly associated, all those you can give us a brief info. Then you can go for the what about the pathogenesis. Pathogenesis is how you can, if it is going to be as flowcharts or something, it is well and good. If not, write in clear points. Need not write everything in paragraphs. You can write as pointers also. That is also fine. Then go for the morphology. Morphology comes as the gross as well as the microscopy. So gross, some 2-3 salient points. Microscopy, if remember 1 or 2 points. And finally, what are the clinical inclination? What is the symptoms and signs the patients will present? And if you know, a point on the therapy. Okay. So this will complete one, any short essay or essay question or short notes in systemic pathology. Okay. So if atherosclerosis is asked, you just say it is, it's the most common cause of your metabolic disorder, right? Atherosclerosis, and you're going to see it in the larger elastic arteries. And it starts with as early as a young childhood as a fat deposit, streaky deposits, and goes into plaque formation. And what is a major problem because of this? It is a causative for ischemic heart disease as well as your cerebrovascular accidents. Next, what are the etiopathogenesis? So etiopathogenesis, first is the risk factors. The risk factors, instead of writing everything as a simple jumbled up paragraph, you can mention as a non-modifiable and potentially modifiable. This is one way of writing. Okay. The other way of writing is you can write as the major risk factors and the minor risk factors. So that way you will, when you study also, when you keep this in mind, at least you will remember 2-3 points in the major risk factors and 2-3 points in the minor risk factors. So that way you will not miss out anything. Okay. Then this is a pathogenesis flow chart. You can always draw it very easily. Even if you don't write anything, this flow chart is there. That is well and good. So starting here, this is the initial, sorry. So it starts with all these initial disturbances in the endothelial vessels, starts with the fibrofatty plaque. And as days goes, the plaque will start growing and it becomes vulnerable. The plaque rupture, what happens? There will be thrombus and embolus. And if it is just a thrombus, it results in critical stenosis or occlusion. If it becomes an emboli, it goes for stroke events and other anomalies. Okay, so this is what we expect when we correct the paper. And you can draw a beautiful diagram of the plaque in which you can, and whenever you draw any diagram, please mark the parts. Okay, you need not be fancy multicolor pencil or something. If you don't have time, you just draw with a pen you have. If you possibly use 2-color pens and just draw and mark these things. So in a atherosclerotic plaque, we'll see if there is an endothelial lining, and within the plaque, is there any fat adipose fat cells are there, and you're seeing any fibroblastic proliferation, some inflammatory cells, and there is a fibrous cap. These are the things we will expect to you. Okay. And what is the clinical implications? So this is another beautiful picture you can see in Robbins. If you can draw this diagram, it is well and good because it explains everything, starting from thrombus, embolism, rupture, and if it go, what are the things that can happen? So the heart, it's going to be MI, cerebral infarction, or it can happen gangrene of the limbs. And the next is going to be an aneurysm. So if this diagram is there, it explains everything. We'll go a little fast. This is just the same picture I just drew. So this is how we expect you to write this topic. Is this clear? Atherosclerosis?
Yes.
Okay, fine.
Yes, ma'am.
Now coming to the hypertension. Hypertension, again, we'll want a definition. Okay. So what is the definition? What is the blood pressure? This is the first line we'll be expecting. You don't take it very, very lightly, because many times some students will write the definition of a higher diabetes value in the hypertension. We have corrected papers like this. So the first thing we will see is what is the definition, what it has. Does the student knows the normal blood pressure values? Okay. Then you can go for what is it? Is it a primary or secondary hypertension? And also you have an entity called as the malignant hypertension. So those definitions you can write as the first data, what are the types. Then you can go for the etiopathogenesis. So blood pressure depends on the cardiac output and the peripheral resistance. What are the factors that is going to affect the cardiac output? What are the factors that is going to affect the peripheral resistance? Everything, you can put this again a flow chart. Okay, so this flow chart will be expecting there. And again, what are the complications? What is this is the you have all the renin-angiotensin system, that everything plays behind the role in the maintaining a blood pressure. So where it gets rearranged, everything, this flow chart we will expect. And finally, you can go for the various complications. So that is much, only so much in hypertension is there. In that, one thing is benign nephrosclerosis. You will see this again in kidney also. So this is a very frequently asked question in the Viva. What is the external appearance of the kidney in the benign nephrosclerosis? Can anybody tell me? The kidney, what is the appearance in a benign nephrosclerosis? What happens in benign nephrosclerosis? It is a leather granule appearance. Leather grain appearance is what you see in the kidney. Whereas in malignant nephrosclerosis, it is going to be, it is a consequence of malignant hypertension. You will see this flea-bitten kidney, small purpuric dots within the kidney. This is called as the malignant nephrosclerosis. These questions can come in your MCQs and they can ask you in the Viva also. Okay. So characteristically, what is the microscopic pattern you see in both benign and malignant nephrosclerosis? The hyperplastic arteriosclerosis, onion skinning, all these things you should write. If you write that and highlight it, that is more than sufficient. What is the definition for malignant hypertension? How much is it? The value? Be a little interactive, please. Should be more than?
120 or 80 mg.
That is a normal hypertension. What about malignant hypertension? 200 by 120, right? Okay, that is malignant hypertension. Next is aneurysm. Again, aneurysm, you know what is it? Is a dilatation. This aneurysm is mostly asked as a short essay rather than a short notes rather than essay question. So we will now first see what is the definition you have written. So I'll just see if there is a word as the localized dilatation of the blood vessels. Is it there or not? And then the cause it is because weakness in the media, that is fine. And I'll see that line. Then I'll see, have they identified what is a true and a false aneurysm? Okay. So when you see the true or false aneurysm, this word I'll see. Then what are the different shapes of the aneurysms? Like you have the saccular, fusiform, and false aneurysm and the dissecting aneurysm. So these images, I will expect you to draw it in the papers. Okay, it's very simple. You can remember that. Okay, and this is about a few words on the etiopathogenesis, how this abdominal aortic aneurysm happens. So most common cause, I'll see if they have written atherosclerosis. And what is a common site? It is below the renal arteries, above the bifurcation of the aorta. And it can occur in other conditions like inflammatory conditions like periatric fibrosis or a mycotic lesions. What is mycotic aneurysms? What is your causative organism? This is a frequently asked questions in the Viva because mycotic aneurysms, we tend to say it is a fungal infection, but it is not a fungal infection. It is a bacterial infection. Okay. And syphilitic aneurysms, very frequent, very rarely I have seen this as a short notes, not that common, but we search for the word this tree bark appearance, obliterative endarteritis, and plasma cell infiltration. So in any syphilitic causative, any part of the body, what you see is obliterative endarteritis. The small endarteries are totally obliterated because of the plasma cell infiltration. Okay, so that is the word we will see. And what happens in the heart? There is going to be aortic ring, valve ring dilatation resulting in left ventricular hypertrophy and carbovenum. So these key words we'll be searching for the correction. Okay, this is just to show you the tree bark appearance. And again, aortic dissection. Aortic dissection is not frequently asked. Again, a very rare question you see. In this, I have just to see if have you mentioned about Marfan's syndrome or everything, and what is the different types of lesions you can see this type 1, type 2, and type 3. And have you written or not, I'll be seeing. This is just a picture of an aortic double lumen aorta. Okay. And as I told you, berry-aneurysm, the cerebral aneurysms, common cause of subarachnoid intracerebral hemorrhage and mycotic aneurysms. Again, these questions will be asked in the Viva and also in the MCQs. Okay. And vasculitis. Vasculitis, like less commonly, but have been asked as an essay question also. Little bit, sometimes it's not a very easy question to remember. Many times I have seen candidates making mistake in this. But you have to remember what is the different etiologies. So vasculitis, you know, it is going to be inflammation and there will be blood vessel necrosis. Fibrinoid necrosis is going to be there. The causative could be infectious, immune complex mediated, direct antibody attack, and ANCA associated. So these names I will be expecting to see if they ask us an essay question as an etiology. And then you can go for classification. That is a large vessel, medium size vessel, and small vessel this. And you can, this is again a word on ANCA antibodies. You should know what is the ANCA antibody, C ANCA, P ANCA, what is that? You should know that. And then I'll just show you. This is one flow picture. If you remember, you will not miss any of the vasculitis. Starting with the large vessel vasculitis in the aorta, arteries and arterioles, coming to the small vessel vasculitis. Okay, so this picture is very beautifully given in our Robbins. This flow chart, you remember, you will not miss out anything. Okay. And if you see, I'll just say two words in each vasculitis. So in giant cell arteritis, it is otherwise called as temporal arteritis. The classical thing we'll see is when you palpate, you will see the temporal artery as a cord-like structure. And also they will have a splitting headache. And microscopy are going to see granuloma, and they are generally associated with elevated ESR and vision abnormalities. So these 2-3 keywords we will search for. And Takayasu arteritis, the first thing I remember is the pulseless disease. Again, you can write the other thing, but this is the one thing I'll be searching for. If you have written this or not, then you have read the text we know. Again, polyarthritis nodosa, it is going to be a small vessel. The small aneurysms are going to be there. Fibrinoid necrosis and eosinophils will be there. And it is one thing associated with hepatitis B, okay? And also renal involvement. Kawasaki disease. Kawasaki disease, it is again important in childhood. It is one of the common cause of what we say like MI in a childhood. That is what we say for Kawasaki disease. It is a mucocutaneous lymph node syndrome of infancy and childhood. So this is something, if Kawasaki disease is child, you should keep in mind. And microscopic polyangiitis, you know, it is they can have a cutaneous lesions like a leukocytoclastic vasculitis, or they can also have a systemic involvement involving smallest arteries and arterioles. They can be a part of your lupus erythematosus, SLE. And Church-Strauss syndrome. Now, what is the name for the Church-Strauss syndrome? What is the reason? Church-Strauss was earlier name. What is the current name? Can anybody tell me? I'm not going to tell you. It's not the current name. I want you to see. And what is the ANCA association with Church-Strauss syndrome? You have to keep in mind. Okay. That was about blood vessels. Any questions you have in the blood vessels? These are the most commonly asked questions and short notes in blood vessels. Anything else you want to know in blood vessels? Shall I move on to the next topic, heart? Okay. So the heart, what are the important, very frequently asked question is MI. So myocardial infarction, you can get short notes, essay, and multiple choice questions. Essay, they can give you as a key, like a case-based full history, like a person presenting with chest pain and presenting to the hospital, name ER, and what is the lab findings, what is the clinical findings they can give you, and you have to diagnose it. And most of the time, sometimes they can ask you what is the laboratory diagnosis of MIS separately as a short notes, or they can ask you what is the complications of MIS as a short notes. Very rarely they've asked for the morphological changes separately as a short note. Otherwise, it comes as a part and parcel of the essay itself. The next IST per se, they can ask us a physics together. Infective endocarditis, rheumatic heart disease, rheumatic fever. These are frequently asked essays as well as short notes. They can come in any part of this. And among the congenital heart diseases, tetralogy of fellow ventricular septal defects, they can ask you. Told you cardiomyopathies per se, then come as an once a while I've seen as an essay question, but not very frequently. It can come as a short notes. And also you have cardiac myxomas. Myxoma, it is easy question to remember, but sometimes when you have not read about it, you might not totally, you cannot manage that short notes. And vegetation of the heart per se, they can ask you as a question. So you can put together every finding and write in that. Okay. So when they ask you ischemic heart disease, you have to just give, as I told you earlier, a brief introduction about what is the ischemic heart disease, what are the group of diseases that comes under in that, and what is the etiopathogenesis. So etiopathogenesis, here we have to write what are the causes of ischemia: demand, increased demand, diminished volume, diminished oxygenation, everything. And the risk factors, this is one mnemonic we have in, we follow, that is Has lipids. Anybody know this mnemonic? So this is one thing you can keep in mind, like Has lipids. So it is easy to keep in mind. You will not miss out the risk factors. And you write a clinical syndrome. These are the four things we'll expect: angina pectoris, sudden cardiac death, MI, and chronic ischemic heart disease going with to heart failure. Okay. So angina pectoris per se has come as a short note. So you should know what is it. Is just a paroxysmal. These are the keywords we will see. Like it is a paroxysmal, and there can be a recurrent substernal or precordial pain or discomfort, and there is no necrosis. Myocardial necrosis is not there. There's a myocardial ischemia is there. Okay. And you have should mention about the variants of angina. You can say about the stable angina, unstable angina, and principal angina, and keywords in each of the type. And sudden cardiac death, well, what are the conditions you can get in sudden cardiac? Because once a while they had asked sudden cardiac death as a separate short note. So it comes under the ischemic heart disease, and what is the most common entity? And it generally occurs when there is a more than 90% block in your coronary vessels. Okay. And among younger age group, it is mostly seen when there is your conduction abnormalities or myocarditis, or one of the common causes to see sudden cardiac death in young patients. Now there is, for a few years, for past 2 years, we are seeing an increased incidence of sudden cardiac death. Possibly there might be an etiology. We'll have to finalize for that. But we are just seeing more. Previously, sudden MI was most common among say fifth or say fourth, beyond fourth or fifth decade. Now we're seeing at a younger age group of even third and fourth decade. Okay. Then what are the about the coronary vessels you should know? You have to remember the coronary circulations very clearly. So generally you have the vessels which affect is your left anterior descending and left circumflex arteries, and sometimes, and also the full length of the RCA, right coronary artery. So these is the triple vessels, commonly called as the triple vessel disease. So these are the three vessels you have to see. So when there is a 75% reduction in your luminal space, only then they start presenting with the symptoms. Okay. So it can present as an occlusive intra coronary thrombus, or it can be a sudden vasospasm, not a thrombus per se, or sometimes there can be a mural thrombosis, that is a blood clot can be detached from the blood vessel or an endocardium and bring about an embolic phenomenon. So these are the various grades of stenosis which can happen in the coronary vessels. This is a very easy diagram you can draw. And also what happens when there is a plaque rupture. So this is a picture you can see when there is a plaque rupture. It can heal by itself, or this can go as emboli, or the plaque will start growing and it can occlude the entire vessel. Okay. So this is one thing you have to write about the plaque change. What are the changes? Once there was a short note saying write about the atherosclerotic plaque and what are the plaque changes that can happen in case of ischemic heart disease. So we'll expect you to draw a plaque with a complete fibrous cap and everything, and another diagram showing there is a rupture in the plaque, hemorrhage and fissuring, erosion into the plaque. Okay. And commonly asked question, which plaque is stable, which is unstable? So when you have a fibrous cap with smooth muscle proliferation, the plaque is stable, so you will not have that many rupture into that. Whereas if it is a lipid-rich plaque, it easily ruptures. Okay. So, So this is just to show the same flow charts. And what is the gross changes you can see? So grossly, what is the transmural infarct? What is the subendocardial infarct? You should know. So transmural infarct usually happens from the endocardium to the epicardium. The entire thickness of your ventricular wall is going to be infarcted, and it is usually seen in the posterior free wall and septum with extension to the right ventricular wall. And subendocardial infarcts, you will see infarct only up to the one third or one half of the ventricular wall. So this can be patchy also, it can be multifocal. And this is the microscopic findings. This question they can ask you in multiple choice. One easy way to remember is the first 4 hours, you're not going to see any abnormalities. Then you see coagulation necrosis and neutrophils in that area. And beyond 7 days, all the neutrophils will start disappearing. You're going to see only phagocytes, that is, the macrophages, as well as granulation tissue. And for a complete scar formation, it takes more than 2 months. Okay. So if the patient dies of sudden cardiac death, you don't see any microscopic abnormality in the patient because it takes at least 4 hours to form any microscopic abnormality or a gross abnormality. Okay. So what are the diagnostic lab diagnosis for MI? It's again another frequently asked question. So presenting symptoms like chest pain, diaphoresis, everything. The first thing you say is ECG, fine. So mention about the abnormalities, T wave, elevation, T wave, all those ECG changes. Then also, what is the cardiac enzymes you look for? Creatine kinase, MB, gold standard enzyme. Also, troponin INT is better. And also CRP can also predict in an AMI in an angina patient. So an angina patient doesn't have an heart attack now, but if there is an impending attack again, you can identify with the CRP. So this is just again a picture in your Robbins to show how come these enzymes are being elevated, because these are there in the cardiac muscles and they tend to get released during a heart attack. So next is, after you have you first stop the definition, etiopathogenesis, what are the clinical syndromes we saw, then we saw about the gross and the microscopic changes, then what are the complications, then we saw the lab diagnosis, and then what are the complications. The complications, it could be because of it can lead to sudden death, which is the most dangerous this, or it can, when they're going to infarct a part of the ventricle, they can result in arrhythmiasis, or they can go for a heart failure totally, or valvular insufficiency. There will be a mural thrombus, and your infarction can expand. So that will result in the heart failure again. Okay. So that was about ischemic heart diseases. Ischemic heart disease, again, very important questions. Generally, there will be 1 or 2 question minimum from this. It can be in a short note or an essay, most cases. So please go through it. And rheumatic heart disease, another very easy question to keep in mind, and very something we'll see cases frequently also. So rheumatic heart disease, first, what is the incidence? Etiopathogenesis, this diagram explains everything. Your streptococcal infection, there is antibody stimulation that is going to cross-react with your cardiac tissue. So you're going to bring about pancarditis. So this is endocardium forming the vegetations. Myocardium, you see the Ashkoff bodies. And the pericardium, we're going to see the fibrinous pericarditis. This is pancarditis. So rheumatic fever, what is the diagnostic criteria? You have to know the major Jones criteria. Modified Jones criteria is important. So you have to write what are the major manifestation, minor manifestation, and the supportive evidence, and what is the criteria to call it. So this is the thing they'll expect you to write very beautifully and easily you can keep in mind. Okay. So again, I think you would have seen this video. I just took it from online only, and very beautifully these diagrams are there. You can make use of it to write and draw the diagrams. And again, what are the lab investigations you will expect? Like routine blood investigations, you will see increased ESR and anemia and leukocytosis can be there. CRP will be elevated. And significant to this is your anti-streptolizin O titers, which is going to be increased, or anti-DNase B test will be there. And more evidence is your throat culture for your gram-negative beta hemolytic streptococci. Okay. So other findings, you can have ECG findings and also echocardiographic findings also. That was about rheumatic heart disease. Rheumatic heart disease, again, frequently asked question, very simple question, easily you can answer it. Next is infective endocarditis. Infective endocarditis starts from the, it most commonly comes as a short notes, not seen as an essay question. Sometimes rheumatic heart disease, they can ask an endocarditis together, they can ask as an essay question. Okay. So you have to mention about the various layers of the heart and what is the most common heart that is going to be affected. And this diagram, you can see the mitral valve prolapse people, aortic valve when it is bicuspid, or when there is a intravenous drug abuses. These are the risk factors. The other factors is here prosthetic valves, congenital heart disease, and rheumatic heart disease. And based on the organisms, you can have a infective. This can be in the. This is a beautiful diagram. I mean, a chart. You can reuse this thing because this is a highly virulent organism, Streptococcus. Sorry, it's a low virulent organism. It is going to affect your damaged valves. Whereas Staph aureus, which is a highly virulent organism, it is going to affect both damaged and healthy heart. So this is something we will look for if you have written this or not. And what are the clinical manifestation? That is a salient point in infective endocarditis. So that is mainly because of all the bland or septic emboli that is happening there. A constant bacteremia is there in the circulations and the immune complexes. So you can write all the various lesions you see, aorta, oscillus nodes, aorta, Janovi lesions, splinter hemorrhages, rod spots, clubbing. Multiple questions are there in vivas for in this particular topic. And then what is the lab findings again? What are the abnormalities you're going to see? And there can be anemia because the patient is a cardiac patient, so there will be an anemia. And there will be thrombocytopenia and leukocytosis because it is a septicemia. You're going to see an increased bacterial infections. There will be a leukocytosis, elevated ESR also will be there. And when these, there is a vegetations formed in your infective endocarditis, they can go and affect and lodge in the kidney and affect renal function, resulting in proteinuria, microscopic hematuria, and red cell cast. Again, serology you see for the INA bodies and circulating immune complexes, and blood culture is the most important thing for diagnosis. So you have to know the diagnostic criteria. Generally, we want to have two separate blood cultures for the microorganism positivity, and you have to see for the other clinical pictures and put together. You bring the diagnostic criteria for infective endocarditis. So this is a modified Duke criteria. So you have to have generally we say definite, possible, or rejected. So first definite is you have the culture in the blood culture positivity, you have vegetations, and also the patient is having other intracardiac abscess or anything. That is the first thing. Possible, you have any of the two major and few minor criteria. Sometimes the patient presents with the symptoms, but the disease disappears after use of antibiotics within a week. So in that case, you can reject. It is a rejected infective endocarditis. Next, cardiomyopathy. Cardiomyopathy short note very frequently, and these are the most common. This table enough, you can remember everything. For the types, dilated, hypertrophic, and restrictive. The ejection fraction, how much is going to be there? What is the type of heart failure you come across in cardiomyopathies, and what are the common causes seen in each of the conditions? Okay, so dilated in alcoholic, genetic, or hemochromatosis, and hypertrophic, it is idiopathic or mostly it is genetic. Sometimes seen in infants of diabetic mothers, and restrictive, most commonly you have to think of amyloidosis. So this is again a flow chart from our Robbins saying about the various causes, and Robbins also gives a table mentioning about the various different causes, congenital causes you can get cardiomyopathy. Okay. As I told you, cardiac myxoma, very small short notes mostly. It doesn't come as an essay at all. And you have to, these are the key things I'll see. If I have mentioned, if I see it is a common primary tumor, it is a benign tumor. It is in the atria, valve obstruction most commonly. And about this Carney's complex, I will see. So you know Carney's complex, right? Autosomal dominant inheritance, you will see cardiac and extracardiac myxomas, pigmentation, and endocrine overactivity. Okay. So this they can ask you what is Carney's complex, what is Carney's syndrome. Okay. So read about it. So you can mention those things. And among the congenital heart disease, as I told you, of tetralogy of Fallot can be asked. So in those tetralogy of Fallot, it is good if you can draw the diagram mentioning the various anomalies and just write what is the pathogenesis in that. That is more than sufficient. Not in depth, we will ask for this. Similarly, VSDs, ASDs, all that way only. Not very commonly as ASDs, very rarely have seen. VSDs have come. coarctation of aorta, I've seen questions asking. In all those things, we'll expect what is the anomaly there. What is we expect to see the diagrams in that. Okay, so we're done with heart. Any queries in this? Anand, Geeta, Hari, Harishma, some of you answer. There is one Steve Jobs. Okay, so we'll go to the next topic, that is lung. Lung again loaded with questions. All the COPDs, bronchial asthma, emphysema, bronchiectasis, chronic bronchitis can come as a short note or an essay. Okay, and pneumonia again can come as an essay question. Bronchogenic carcinoma can come as an essay question. And all these cases, they can give you as a case history, and they can you can identify. They'll ask you to diagnose it and write about it. Okay. So lung, ARDS, these are the various short notes you can get other than those things. So just go through that. So you should know what is frequently asked questions in the Viva, what is obstructive lung disease and what is restrictive lung disease. So we'll expect the student to understand, like, obstruction is there is limitation to airflow because there is an obstruction in the pathway. Whereas restrictive lung disease is because their lungs parenchyma is not able to expand, so the capacity is decreased. So that is restrictive lung disease. So in what are the 4 conditions you see in obstructive, you should tell, and in the all the other like pneumoconiosis, sarcoidosis, interstitial lung disease, everything comes under the restricted lung disease. And you should know about the pulmonary function test. What is FEV1, FVC, forced vital capacity, total vital capacity, all those things they will expect you to know. So those are important. So risk factors, the first thing is smoking. So you can mention about it, and occupational exposures like dust, gas, fumants, and alpha-1 antitrypsin deficiency. It's a congenital condition. Mostly in emphysema, it is mostly pronounced there. And symptoms, dyspnea and cough will be the usual in most of the COPDs. Wheezing usually with asthma, and cyanosis because of your oxygen hypoxia. And when the problem is in the lung pathology, you will have a right heart failure. So you will have the symptoms of right heart failure also. And there can be weight loss and anorexia because of a chronic inflammation. Okay. So on physical examination, when you're going to see a barrel chest, this is a word you can remember in emphysema. That is a terminology we see. Quiet heart sound. Because of the emphysematous lung, you will not be able to hear the heart sounds properly. Sounds waves will not be conductive. So that is one thing. This is a clue they are going to give in the examination findings. And CBC, your hemoglobin will be increased because of the low hypoxic level. The erythropoietin will be stimulated, so there will be more of hemoglobin production. Hematocrit will be high, so there will be polycythemic. It's a relative polycythemia, not a primary polycythemia. And your acid-base gas analysis, you will see pH is decreased and PCO2 is going to be increased. So this is the value you should remember. Force expected volume will be decreased, and FE1 FEC ratio is going to be decreased. PLC is increased, FRC is going to be increased, and residual volume will be increased. So the residual volume is going to increase. The amount of oxygen reaching the tissues is going to be very much decreased. So when I say emphysema, you have to write the definition. It is a dilatation beyond the terminal bronchiole. Then you have to mention what are the types, what is centriacinal pad emphysema, what is a panacinar emphysema, and what is a distal acinar emphysema. And there's a beautiful diagram picture for Given and Robbins. You can draw that and condition. And generally, they are called as pink puffers. If you write that, you'll be very happy. And chronic bronchitis is the blue bloaters, right? You see again here, it is a clinical diagnosis. So it is a clinical diagnosis. You're going to see thickened mucus glands, which is measured by the read index. You write the read index words and you can underline it. And there will be increased patients is going to present with clinical symptoms like cough, everything for 3 months for 2 consecutive years. Then you brand the patient as chronic bronchitis. Okay. So this is what are the conditions that are going to exacerbate any bacterial infections, viral infections, or other conditions like COPDs. And bronchiectasis, the next COPD, it is a destruction of the smooth muscle. It is a permanent destruction, okay, that you should remember. It is a permanent destruction and dilatation of the bronchi and the bronchioles. So what are the various conditions you should see? So this is question they can ask you in the Viva also, and also they'll expect you to write what are the congenital conditions. So cystic fibrosis, cartilaginous syndrome, primary ciliary dyskinesia. These are the words they'll be expecting there. And when there is a severe necrotizing pneumonia caused by any bacteria, like even your tuberculosis, they are going to bring about repeated bouts of infection, resulting in the destruction of the bronchi, causing a bronchiectasis. And sometimes there is going to be a tumor or a foreign body occluding the bronchus in a particular point that will result in localized destruction in the bronchi there. And immune disorders like your rheumatoid arthritis, SLE, everything, because of your inflammation, immune response, there can be destruction in the lung parenchyma resulting in bronchiectasis. So if you are able to draw in like this flow charts, that is more than good. Pathogens, what are the host factors, what are the environmental factors. Okay, about bronchiectasis. Next is asthma. Again, another this. These are the words we will say I have highlighted here. It is an obstructive disease. Again, there is hyperreactivity, and it is a reversible. It is a reversible airway bronchospasm. Okay. So again, there will be intermittent reversible obstruction. And if you see the pathways, there is going to be hypertrophy and hyperactivity. What are the two types? Atopic or allergic, and non-atopic or intrinsic mechanisms, you should say. So here, this is for the atopic. You have to see the patient is predisposed to allergic tendencies. So they are going to get stimulated. They are going to release your IgE antibodies. This triggerance can be because of allergens, viruses, cold, irritants. Mostly people say I have dust allergy. Even a small speck of dust will bliss. Even exercises, when they are going to stimulate your muscles, they can release the muscle will get activated. They are going to release the histamine, leukotrienes, and cytokines, bringing about your inflammation and tissue modeling. So this is a beautiful picture. If you're going to draw that, that is more than sufficient. This, if you can, you draw, it is showing the destruction of the mucociliary apparatus over here. It's totally gone. And you can see your eosinophils here, nice orangish granules, spectacle shaped in nucleus, and they are released from the blood circulation. This is the endothelial cells. They're coming out of the endothelial cells. They are getting arranged here, and they're bringing about, say, secreting your, all your enzymes, histamines, and everything, and bringing about the bronchoconstriction. Okay, so that is non-atypic is not related to IgE, generally probably because of some hyperirritability of the bronchial tree, which can be triggered by infections. They bring about non-atypic. Okay, so when you write the morphology, what we see is there can be small collapse, but there is a bronchoconstriction. So the mucosa is going to be thickened, and there will be mucus plugging in the mucosa. Because of that mucus plugging, you will see what we call as the Kirschmann spirals and the Charcot-Leyden crystals. So this is a picture to show the morphology. If you can draw it, it is well and good. If not, fine. And Kirschmann spirals you can draw easily, and Charcot-Leyden crystals you can draw. These are something we'll expect in a essay question of a asthma. Okay. So this is a table. If they ask you COPD per se as a short essay question, and you can write 2-3 points for each and everything. And if you draw this particular table, it is well and good. Okay. What is a clinical condition? What is the side? Mostly, if you see emphysema is in the acini, small airways in the bronchial, others are in the bronchus. What is the major pathological changes? What is the etiology? What is the signs and symptoms? Okay. This concludes all your COPDs. Next, you have bacterial pneumonias. Again, pneumonias, you have write the definition because of inflammation and consolidation. And you have, it is a restrictive lung disease, right? So what are the two types? Lobar pneumonia and bronchopneumonia. So this diagram will expect you to write what is the what is the entire lobus affecting. This is going to be a patchy. That is a bronchopneumonia. Okay. And what are the various syndromes associated? It can be a community occurred pneumonia or community occurred atypical pneumonia, aspiration pneumonia. It could be associated with the granulomatous disease like TB and histoplasma, or in immunocompromised people. Then what are the stages of pneumonia? This is a picture you must draw for the exam. That is the gray starts with the congestion, red hepatization, gray hepatization, and the resolution. Okay, this pathogenesis, and about the various organisms that is associated with pneumonia. So this you have to remember one thing, like staphylococcus mostly in IV drug abuse and nosocomial infection you have to keep. Pseudomonas again in most common in nosocomial conditions, and transplant recipients you see Legionella. Okay. And what are the complications of pneumonia? You have to list out all the conditions. And what are the diagnostic? Any disease, they can ask you what is the lab diagnostic test you have to do. So see for all these things, gram, stain, sputum, everything, you can list out the diagnostic techniques. Lung abscess is a short note only, not as an essay question. So it is a localized suppurative necrosis. So what are the roots, most common causes in aspiration, followed by from a bacterial pneumonia or a bronchial obstruction. Okay, you have to write that. So you have concluded lungs. Fine. And one important two questions I have left in lung. That one is the bronchogenic carcinoma. Bronchogenic carcinoma can come as an essay question. So you have to write what are the types of bronchogenic carcinoma, what are the squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and also your paraneoplastic syndromes associated with the small cell carcinomas, you should remember. Okay, it's again a very frequently asked question. And another question is your pneumoconiosis, your silicosis, bagazosis, berylliosis, all those things they can ask you as a short note and a essay question. Short notes, not as an essay question. Next, okay, coming to GIT. GIT again, you have multiple questions in this, but it is relatively easy. You can keep them in mind. First question from the gastric esophagus topic per se, you will see mostly short notes. Your Barrett's esophagus, achalasia cardia. These are frequently asked as a short note. So back a Barrett's esophagus, I'll search for the word intestinal metaplasia. If you have written that for me, that is more than sufficient. And what is the significance? It can turn malignant. So that is the thing I'm going to search for when I'm going to correct the paper. And if you have understood that or not. And next you have achalasia cardia. Again, it's a term. If you write the diagram, you write what is the achalasia cardia, what is the treatment done for that, that is more than sufficient. And coming to essays, not frequently we come across in esophagus. GIT, you have peptic ulcer disease as a short note, essay, MCQs is a frequently asked questions. Okay. And they can give you the challenge. What I feel among the students is they'll describe as an ulcerative lesion in the gastric. They give us a case history. And if you sometimes gastric carcinoma is mistaken for a gastric ulcer disease, a peptic ulcer disease. So see for the keywords, like they say it is, they are going to having a very hard indurated ulcer, irregular ulcer margins. What's the difference between a benign and malignant ulcer? If you remember, you can identify this. And if they give a history, like there was some atypical cell seen in the biopsy, then it is easy for you to conclude it is a carcinoma gas stomach and not a ulcer stomach. Okay. And again, carcinoma of the gas stomach is as an essay question. Colorectal carcinoma is very frequently asked essay question. Cirrhosis in the liver, yes, ask us an essay question and also as a short note question. Next, you have a viral hepatitis per se, they can ask you as a essay question. Okay. So they need not go for the cirrhosis. They'll ask about viral hepatitis, portal hypertension, alcoholic liver disease, usually as a short notes. Hepatocellular carcinoma can come as an essay question or a short code question. Acute pancreatitis, again, an essay question. It is a possibility, you should remember. Carcinoma of the pancreas is usually as a short note only. And these are short notes, like difference between benign and malignant ulcers. What is a gross and microscopic features alone they will ask you. That's the reason you have when they ask you such questions, you need not write about the etiology, pathogenesis, everything. You just write gastric ulcer, peptic ulcer disease. What are the gross findings? What are the microscopic findings? You must draw diagrams for all these questions. Again, difference between Crohn's disease and ulcerative colitis, you have to know this for sure because they will definitely ask you in the Viva. That is sure. And again, as a short note and an essay, this is a probable question. So when they ask you as an essay question, don't panic like how much you will write. You write briefly about everything. You can write make a table and write as a Crohn's and ulcerative as a comparative this also. That is also more than sufficient. Okay. Gallstones, again, short notes, not as an essay question. Zollinger-Ellison syndrome, short notes. Jaundice, mostly as a short note only, but frequently 1 or 2 times I've seen as an essay questions. So when they ask, I will discuss that in the subsequent slides. When they ask you about jaundice, we'll expect you write what is the definition, what is the causative, like pre-hepatic, hepatic, and post-hepatic. If you classify like this, then we'll be happy that you have understood the topic. And also in the Viva also, they'll expect you to answer in such a way rather than listing out the causes randomly. Okay. Again, anything, hemochromatosis, Wilson's disease, everything can come as a short notes. Pleomorphic adenoma in salivary gland, you have only this pleomorphic adenoma frequently asked. Once in a while, I've seen mucoepidermoid carcinoma, but not very rarely. Actually, in your objectives given in thing, pleomorphic adenoma is there. So just read about it. Leukoplakia, achalasia, malabsorption syndrome, IBDs, and Helicobacter pylori. All these are the same questions which is going to be asked as either as a short note or an essay. And chronic gastritis, again, they can ask you as a short note. So nothing much to write in that. So you have to mention it is the inflammation of the gastric mucosa. It can be accompanied by atrophy or epithelial metaplasia. That is the intestinal metaplasia. That is something we always look for that. And there is no dysplasia. So one is a non-erosive gastritis in which you're going to see a autoimmune gastritis. You're going to see antibodies usually against which is your intrinsic factor, which is seen in the pernicious anemia patients. And also another important is your Helicobacter pylori. This they can ask you separately as a short notes. Just H. pylori they can ask you. So in that case, we will expect you to write some amount of your microbiology also in the pathology thing. You have to mention what it is, like a non-spore bearing, S-shaped, gram-negative rod. If you write that, it is good. Then how does it survive in the acidic medium? How does a H. pylori survive in the acidic medium? You should mention that. And you have to see neutrophils in the gastric epithelium. So that is what we expect in the. So H. pylori associated infection and also autoimmune gastritis, you have to write this. This is again for the ulcer disease. We'll expect you to draw this particular diagram. So please see this. And I think we saw all those things. So peptic ulcer disease also, again, it overlaps. What is a common site? You can see it is in the first part of the duodenum also. You have to mention that. And what is a misbalance between your acid secretion and your mucosal protection? So that is what is happening. Imbalance between the mucosal defenses and the aggressive forces that overcome the defenses. So this particular diagram we will expect. So this flow chart we will want you to draw. What are the defensive forces? Your mucus flow, your mucus secretion, bicarbonate secretions. What are the implanted defenses like delayed gastric emptying, duodenal reflex, all those things. Aggravative factors we'll see for H. pylori and NSAIDs. These are the two things we will see. Of course, cigarette and alcohol you can add it. Next is what are the mechanisms you have induced mechanism of H. pylori infection. This is when they ask H. pylori assay per se as the short note, these things you have to mention about the cytokines that are being produced, about the urease which is going to secrete and makes the environment non-toxic for itself. Okay, so thus it brings about this. And also VAC-A causing epithelial injury. This VAC-A will expect to write, and it's going to impact the bicarbonate production. And also it also stimulates your B lymphocyte accumulation. Hence you see lymphoid aggregates in those areas. Okay. So these are the things we will expect there. Just to show what is a benign ulcer, it is the most compact punched out small ulcer. It is a border overhanging, it is not indurated, and generally ulcer base is clean. Whereas a malignant ulcer, it is a indurated ulcer, irregular ulcer, and the borders, the base is going to be necrotic. Next comes gastric carcinoma. Gastric carcinoma, you have to, it's a common malignancy of the stomach. So if you, the incidence highest in Japan, that's, if you see that country, we are so happy because that is, they are doing so much renovation studies in gastric carcinoma because the incidence is so high there. Environmental and dietary factors only. So these are the initial, as I told you, first about epidemiological data, then the etiopathogenesis. In the etiopathogenesis, you have to see other things apart from your diet and nitrites and spoke foods. You have to mention about your chronic atrophic gastritis resulting in intestinal metaplasia and also H. pylori infection. And what is the classification grossly? What are the four types you see? You're going to see an exophytic growth, a flat, depressed, excavated growth. And what is linitis plastica, where you're going to see a diffuse type of gastric carcinoma, tumors is infiltrating the wall of the stomach, giving a leather bottle appearance. So these are the things you have to highlight in that. And what is a microscopic classification? You have the Lauren classification stating as a diffuse in the intestinal type, So you mentioned what is you see in the intestinal type, what you see in the diffuse type. Okay. And these anybody will write, but you want to have more brownie points. We will see for the molecular mechanism you have mentioned or not. See for the intestinal thing, I will expect you write the APC gene mutation. Yes, he has written. And if it is a diffuse, I'll see if there is the, you have mentioned a CDH1 mutation for the E cadherin, which is there or not. So these words, if you write, you get more brownie points in that. And what is the clinical pictures of what is Virchow's node, what is Krukenbeck's tumor, modes of spread, where all it goes. Okay. System Mary Joseph nodule, all those things we'll expect there in that. Okay. So gastric carcinoma, if it comes, is actually a very easy question we see, and it is something you can easily score marks also in that. So write in this order, you will not miss out anything. Next, coming to your IBD. As I told you, IBD, if they ask, very frequently asked question. So this is a table you can put and differentiate it. So what is Crohn's? You should remember from the mouth to the anus, Crohn's can affect any part of the intestine, whereas ulcerative colitis is limited to your colon. And both are going to be immune mediated disorders only. Here there is a transmural inflammation. So it's very important, easy to remember. If the entire part of the intestine anywhere there is going to be the transmural inflammation is going to be patchy. So you will have normal areas in between. That is the reason your GI tract is intact. Whereas in ulcerative colitis, it is going to be a continuous lesion and it is going to affect only the mucosa and the submucosa. That is the reason it doesn't go for a fissure or rupture that easily. So those things you have to mention. And granulomas you see in Crohn's, ulcerative no granulomas, and skip lesions in Crohn's, no skip lesions in ulcerative colitis. Fistulas, because it is going to be a transmural inflammation, you will see the rupture of the intestine, so you see as fistulas, whereas ulcerative colitis you don't see. And when there is only mucosal ulceration, the adjacent normal area, there will be hypertrophy resulting in pseudopolyps formation. Okay, here there will not be any pseudopolyps. So these are the things you should remember. This is a granuloma you see in Crohn's disease, which is highlighted here. These are the pseudopolyps you're going to see in your ulcerative colitis. And incidence of malignancy is higher in ulcerative colitis rather than Crohn's. It's the same thing starting with what are the macroscopic features and everything. Okay. So you can write this frequently. They can ask you a clinical scenario also. A patient coming to you, surgeon with a fistula in the perianal fistula. He was treated initially, but he was coming recurrently for an perianal fistula and altered bowel habits. So if they did a colonoscopy, what is the most common etiology? It could be, it's most likely to be a Crohn's disease. Another thing is tuberculosis, which can still bring about multiple fistulas. Okay. And a word on this, moving to the neoplastic entity, all the polyps, your hyperplastic polyps, serrated polyps, they can ask you as a short note. That is something little, not a very easy question, but there are some questions are kept for your, that is nice to know areas. So those questions will come from the nice to know areas. And this polyposis syndrome, they will ask you very frequently in the short notes and also in the vivas. So it is particularly autosomal dominant. That one thing you will see, they will have multiple polyps. What is the criteria? They will have minimum 500 to 2500 polyps. They are going to be there. What is the chromosome APC gene, where it is 5q gene, you have to remember. And the only thing is, it is risk of cancer is almost 100%. So patient will undergo a therapeutic colectomy for this patient even before the tumor arises. Just to show the number of polyps, in few polyps are turning malignant here. This is a malignant polyp, this is a malignant ulcer, and these are the multiple polyps. Okay. So I'm just specifically telling, then even in colorectal carcinomas, molecular pathway of colorectal carcinoma per se can come as a short note. Okay. So you have to mention about the beta-catenin APC pathway very beautifully in that. So again, adenocarcinomas, most common colorectal type is adenocarcinoma, and it's mostly in the elderly. And from adenoma to carcinoma, it can go. So there is a patient is having adenoma, it can turn to carcinoma. If the patient is having a fibroadenoma in the breast, it doesn't turn into an invasive mammary carcinoma. Whereas there is an adenoma, it can undergo a carcinoma frequency. So if you see an adenoma, you're supposed to remove it. You cannot wait and watch. Okay. And other condition, pre-existing ulcerative colitis, as I told you earlier, polyposis syndrome. And you have a HNPCC, hereditary non-polyposis colorectal cancer syndrome is also there. Lynch syndrome, we'll see about it. Dietary factors, you have to mention, high fat content increases, whereas dietary fiber rich will reduce the incidence of this. And use of aspirins and NSAIDs are protective against colonic cancer because they inhibit the cyclooxygenase pathway, COX-2. Okay. So these are the two pathways you'll expect. One is the APC beta-catenin pathway, adenoma carcinoma sequence. Then you have the mismatch repair pathway, that is a microsatellite instability pathway. So this diagram we will want you to draw. Please practice this. This is very, very important. They can ask you part of an essay question or separate as a short notes. And even in Viva, they'll ask you, okay? So what is the first hit? What is the second hit that happens? And finally, when the carcinoma comes, starting with the normal mucosa, next adenoma formin, and then is the carcinoma. This is a very, very important thing you have to remember. And this is a APC beta-catenin pathway, how the beta-catenin, which is in the cytoplasm, will combine with the APC gene and go into the nucleus and bring about proliferation. Okay. So what is a common site? It can happen in the cecum, ascending colon, or rectum and sigmoid. So what is the difference between the right-sided colon carcinoma and the left-sided? What will be the symptom? In the right-sided, there is more space. Cecum is a voluminous area. It has enough space and time for the tumor to grow before it brings about symptoms. Whereas on the left-sided, it is going to be an annular or ring-like obstructive symptoms will start coming. So the patient will present much earlier. Okay. So these are about this. Microscopically, can you differentiate between a right side and a left sided carcinomas? No, they are going to be the same. Okay. Then how will you, again, diagnostic lab diagnosis, if they ask, first clinical symptoms, and on examination, you can see for the general examination, any lab diagnosis, if you're going to say a few words about clinical presentation, it is fine. Start with the general examination, systemic examination. What are the things you're going to say? You have to mention about digital rectal examination for the mass, and also occult blood. See for any occult blood is mostly seen in the left-sided, right-sided colonic carcinoma. And when in our setup, like an elderly male or a male patient presenting with anemia, anemia is more common among females because of their menstrual bleeding happening throughout their reproductive cycle age group. Whereas in a male, there is no loss of blood on a day-to-day basis. So when they present with an microscopic hypochromic anemia, it is essential to rule out for these occult blood in the stools to see for if there is any bleeding in the GI tract. Okay. Then serum markers, CEA, carcinoma embryonic antigen, is going to be elevated, but it can increase in other conditions also. But still, we can see for that. Excuse me. So colonic carcinomas is very, very important. Frequently asked question, you have to remember. And anal carcinomas, melanoma of the anal canal can happen. In that case, whatever you read in skin topic also can be overlapped here. So what are the findings you commonly see in anal canal? Just 1 minute, I'll come. Okay, let's resume. Next, small intestine questions are much less in small intestine per se. Malabsorption syndromes, they can ask you, tropical sprue, all those things, but not very frequently asked. Just again, another tumor you can get in the GI tract. So they'll expect you to mention about the c-kit markers. It is a diagnostic marker, right? When the tumor cells are positive, you are c-kit, you can call it as a GIST tumor. So those things they'll expect in that. Lymphoma of the GI tract, you can get lymphomas, but per se you don't get much as a short note or this in GI topic per se. Okay. Next. Jaundice. Jaundice is a question they ask frequently, and many a times students they are not able to write very clearly about jaundice. So first is the definition you write. What is when will you call a person as jaundice? When the bilirubin level is more than 2 to 2.5 milligrams per deciliter. What is the clinical presentation? Yellow skin and the mucosal surface. And what are the three stages? It can be a prehepatic or a hemolytic jaundice, hepatic problem within the liver, and obstructive or the posthepatic. So this table you will see should know about the normal bilirubin metabolism, starting from how it is produced from the RBCs. The heme oxygenase getting converted to biliverdin. Biliverdin is converted to bilirubin, and they are going to combine with your glucuronidase transferase, and they are carried to the bile canaliculi. So, and they undergo enterohepatic circulation. You should know about the urobilinogen and what is the free bilinogen it's there, and how it is going to divide into the feces and the urine. This is how the enterohepatic circulation happens. So this you can mention. And what are the each condition, like prehepatic, there is going to be increased protection. Post-hepatic, there is an obstruction, so there is not able the the bilirubin which is produced is not able to be conjugated there. All those things you can mention. And investigations, these are the common investigation you should mention. What is the cause? Like liver biopsy is ultimately to know what is the reason for the jaundice. So I usually ask question, what are the signs of clinical signs of liver failure? So starting all the from head to foot, what are the things you're going to see? Hypogonadism, spider angina, gynecomastia, weight loss, muscle wasting, poverty above and plethora below, what we say, right? Ascites, caput medusae, all those things you have to mention. And what are the life-threatening complications in liver complications? Because of hepatic failure, they'll go for multiple organ failure, coagulopathy, encephalopathy, hepatorenal syndrome. And on long-standing, they can develop cirrhosis, portal hypertension, and malignancy with the chronic diseases. They can develop a hepatocellular carcinoma also. Okay, this is a diagram to show what are the things from head to foot, what are the changes that can happen in a liver cell failure. Okay. In portal hypertension, if they ask also, you can say it is the prehepatic, posthepatic, and intrahepatic, and write down the causes and conditions. Next, word on viral hepatitis. Viral hepatitis frequently asked short notes, very easy to write also. Whenever we say viral hepatitis, we mean the hepatotropic virus like A, B, C, D, E, and G. So those are versus viral hepatitis. Even the other viruses can also bring about inflammation in the liver. So this is again another table you can keep in mind about the A virus. It is usually, among this, only the hepatitis B virus is a double-stranded DNA virus. All others are single-stranded RNA virus. And more chronicity is associated with HBV, HCV, and HTV. Others doesn't have a chronicity. And the mode of transmission is fecal-oral in HAV and HEV, whereas others are going to be parenteral. And chronicity, carrier state, everything occurs only in the HPV and HCV. Okay, so remember that. It's easy to this. Coming to chronic hepatitis, you have nothing, any of these things can come under the chronic hepatitis short notes. They can ask you about Wilson's disease, they can ask you about alpha-1 antitrypsin deficiency, or they can ask you chronic alcoholism. So alcoholism, you have to know about the alcoholic liver disease and non-alcoholic liver disease. They can come as a separate short note. So what happens in non-alcoholic liver disease? They can start with the steatosis, that is fat accumulation in the liver. It could be a macrovesicular steatosis or microvascular steatosis, and resulting bring about oxidative stress, resulting in lipid peroxidation and fibrosis, can cause the mammary body deposition as well as hepatocyte injury. Whereas in alcohol, they are going to, they are endotoxins. They are going to bring about destruction of the hepatocyte. Peroxidation will be there, inflammation is going to be there, and there are going to be fibrosis. So this you have to know. And what are the various alcoholic liver disease? It starts with steatosis, then steatohepatitis, and end stage is going to be cirrhosis. Okay. So what some important hemochromatosis, other stains you can see for the iron stains, for the iron deposits. Alpha-1 antitrypsin deficiency, you will see PAS-D stain, that is a PAS periodic stain. If you put, you can see the hyaline cytoplasmic inclusions. Wilson's disease is diffuse copper staining, like rhodamin staining. If you do, you can demonstrate. Okay. That is about chronic hepatitis. And cirrhosis per se, it is an end-stage liver disease. you can, the important thing we see, it is generally an irreversible, and there is going to be destruction, regeneration, fibrous septa, as well as regenerative nodules. So when we ask a definition of cirrhosis, we expect you to write all these things there. And classification based on the morphology, it could be a micronodular or macronodular or mixer. Based on the etiology, these are the causes. You can start with the most common causes: alcoholic liver disease. Next is viral hepatitis, biliary disease, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, cryptogenic, that is we don't know, and hereditary metabolic disorders or other causes. Okay, so that is about cirrhosis. And HCC per se, all the liver tumors, mostly they will ask you, hepatocellular carcinoma is commonly asked. When they ask you hepatocellular carcinoma, you can mention about what is the two types, about the fibrolamellar variant and the classical hepatocellular carcinoma, and what is the patient is going to present with a severe jaundice, or sometimes the patient is going to present with only vomiting, hematemesis or something. So those things you can mention. And what is the serum marker, serum alpha fetoprotein is going to be elevated in case of an HCC. So those things you can mention. Other cyst of the liver, they can ask you, like you can get amoebic liver cyst, you can get echinococcal cyst in the liver, and pyogenic cyst is a common you can get in the liver. So that you can mention. That is about, and also most commonly you can also get all your vascular tumors like hemangiomas, that is commonly seen in the liver. Okay, so far liver is done. Now we'll come to the gallbladder and exocrine pancreas. Can we take a pass? Tell me, like anything more you want to know in these about topics? Okay, coming to gallbladder and exocrine pancreas. So stones, gallstones, most commonly, you know, all these keywords like 6Fs, right? Female, fair, fat, fertile, 40, and flatulence. These are the common etiological mnemonics we are associated with cholesterol stones. So there is water insoluble cholesterol with the bile, they form soluble. This is a normal mechanism, and that is increase. There is increased amount of lipids available. They tend to get saturated within the gallbladder to form the cholesterol stones. Okay, and pigment stone is because of a chronic hemolytic syndrome, because of increased amount of hemolysis. There is an increased amount of bile pigments resulting in pigment stones. Okay, and what is the most common presentation, clinical presentation? What is Murphy's sign? All those things you can write in case of a gallstones. Acute pancreatitis can come as an essay question. You know, it is a medical emergency. It is a reversible pancreatic injury associated with inflammation. Common cause is going to be alcoholic as a common cause. Next is gallstones, trauma, shock, mumps, and genetic factors. And lab parameters, most importantly, we look for the serum amylase and the lipase. Okay, so there is a digestion of the pancreatic substance by the pancreatic enzyme per se. The trypsin is getting activated, so that is the reason you see it. Acute pancreatitis. So it is a medical emergency. Chronic pancreatitis, when there is going to be a repeated inflammation happening in the liver, that results in irreversible destruction of the exocrine pancreas. And as the exocrine pancreas get repeatedly affected, it results in the destruction of the endocrine pancreas per se. So mostly seen again in long-term alcohol abuse, obstruction, tropical pancreatitis, hereditary pancreatitis, and CFTRGN mutation. And in the chronic pancreatitis, one entity is the type 1 autoimmune pancreatitis. In this, you have type 1 and type 2. Type 2, you're going to see a lymphoplasmacytic sclerosing pancreatitis, where you're going to see the obliterative phlebitis, storiform fibrosis, IgG4 associated disease. Whereas in autoimmune pancreatitis, it is predominantly neutrophilic infiltration within the epithelium, resulting in epithelial lesions. So they lack the plasma cells. So that is about pancreatitis. So you should remember the acute and chronic, as well as the what is the lab enzymes you have to see for in a pancreatitis. Pseudocyst of pancreatic neoplasms, you have multiple cysts. You should know the pseudocyst is again a complication or is a sequelae of pancreatitis. You're going to see only inflammation, granulation tissue. There will not be any lining epithelium like a serous epithelium or a cuboidal mucinous epithelium is not going to be there. And other cysts, simple cysts, just a flattened cuboidal epithelium, simple mucinous epithelium. And this is a classical picture. It's a sponge-like appearance. This is seen in a serous cyst adenoma. Okay, very classical picture of pancreas. And mucinous cystic neoplasm, most common thing we look for is this have a mucinous lining as the name indicates, and the stroma will have a ovarian type stroma. Okay, it will be ER positive, estrogen receptor positive also. Okay. And IPMN, again, it is going to be a mucinous neoplasm only, but it will not have ovarian stroma, and it will involve the larger duct rather than the smaller ducts. And SPPN, again, young women, you're going to see multiple pseudo papillae. They are going to have, they'll be having grooved extracellular globules, and they'll be positive for beta catenin. Okay. So this is SPN. Again, it is a young women and it is a self-limiting tumor. So generally it has a good prognosis. So these are the tumors of the pancreas you should know. And finally, again, you have the adenoma carcinoma sequence as we saw in colon. In pancreatic carcinomas, because initially starts with the KRAS mutations, you have one pancreatic intraepithelial neoplasia 1A, 1B. Then you have the P16 inactivation resulting in 1, 2. And the next hit is going to be your P53, that is your policeman gene is affected. That is the tumor suppressor gene, right? And SMAD4 and BRCA2 is going to be affected, resulting in invasive carcinoma. So this carcinoma, adenoma carcinoma sequence, they'll ask you in pancreatic carcinoma. It's not an adenoma carcinoma. It is starting from the intraepithelial neoplasia going to an invasive carcinomas. Okay. So far we saw about most of the lesions in all the 6 topics which I mentioned earlier. Other than this, I had missed tuberculosis in your respiratory system. I think it is covered in your infections. If not, tuberculosis also they can ask you as an essay question. So tuberculosis, when they ask you, you have to mention about what is the etiology and what is it, just epidemiological data, what is the incidence, everything. Etiology, mention about the primary complex, secondary complex, progressive pulmonary, primary complex, all those things, your pulmonary disease, everything you have to mention about it. And also gross and microscopy, mention about the various complexes, what is Ghon's complex, what is Simon's complex. These things they can ask you in your MCQs also. And what are the various special stains you can do, what is the culture medium for tuberculosis, bacilli, all those things they'll expect you to know. Okay. So, Nakshal, these are the major questions I have shared with you. And if you are able to follow all these things and remember 2-3 points in each of the questions, you can definitely do well in your exams. Thank you. Any queries you have, you can ask me. I can guide you in that.
Thank you, ma'am.
Any questions, Pa?
Ma'am,
Yes, ma'am. Tell me.
we can remember the chromosome number like
Which one?
5q12. Any question, ma'am? Like
Chromosome numbers or?
Yes, like 5q12 or something level
See,
q12.
நீங்க என்ன பண்ணுங்க, don't remember the 12 well. You just remember 5q. Okay. That is
Okay,
for
ma'am.
very few things because APC gene is important. You remember 5q, that is enough. If you remember 12, leave out 12. Just remember 5q, that is enough. Remember it is an autosomal dominant. If you didn't write 5q, they're not going to penalize you or anything. They're not going to reduce much marks. Write that, you get more marks. We want to know that it is, you should remember it is an autosomal dominant condition and it has 100% penetrance to the recipients. They are going to present with the tumor. So that if you remember, that is more than sufficient.
Ma'am, like that,
I'm telling you, when we correct the papers, we will see all these keywords only. We will not be going through, oh, he didn't write this point, he didn't write this point. If you have a good understanding of that particular topic, it is good. Solunga, ask me.
ma'am, like that, could you tell some important chromosome numbers we have to remember? Only that we can revise.
You want all the important chromosome numbers. The first topic, blood vessels, actually nothing much is there. Don't want to remember much in that. Then heart also, cardiomyopathy is, although there is genetic disease, you don't want to remember all those things. That is not there. Chromosome numbers and gene names you should remember. Like if I say KRAS mutations, pancreas, you should know. Then your endocrine organs, all your RAS mutations happening in thyroid, everything you should know. BRAF mutation. Other translocations in the lymphomas. Lymphomas level 11, 14 translocation, 14. Other one is very, very important because they will ask you a question. You're supposed to know that. If somebody has a notes or something, I'll see if I can, I'll try to share that with you. Okay. Important translocations. Gene per se usually solluvom. And cystic fibrosis, chromosome 7, right? Others are fine only. But translocation, you should remember. What is a translocation seen in CML? Chronic 922. Why it is very important? It has a history associated. That is the first genetic disease, mutational disease we identified, and we have a targeted therapy for that. So, every research is going to identify the mutation, give for a tailored therapy for each person. Now they are seeing, like, if it is a lung adenocarcinoma, they will expect you to know about EGFR mutation. It is an epidermal growth factor receptor, EGFR mutations. It is very prevalent. They do on a day-to-day basis on all the patients for with adenocarcinoma, because when you give a targeted therapy for that mutation, the patient's side effects will be less and the response is good in those patients. And the madri varum. I'll see if possible. I'll try to write down everything and share it in the group. Okay?
Okay, ma'am. Thank you.
Anything else? Draw, I'm requesting again, draw many flow charts. Need not be very pretty diagrams all, but you draw it. So that way you will save time also. It is easy. They will know that you have understood the topic. That is enough. They will not count the number of papers. Don't think the more the number of papers I read, I'll get marks. No, it is not like that.
Can you share the PPT in group?
In the PPT, yeah.
Yes, ma'am.
I didn't put much in the PPT. I just took from all our PowerPoints, important points. I'll share it. Not a problem. I'll share it. Okay. Don't know how far it will be useful. Definitely, I'll share it with you people.
Thank you, ma'am.
Okay. So shall we close it? Anything else you have? Please ask me.
Hello, ma'am.
Yes, tell me.
Yes, ma'am. Ma'am, if the session is over, we'll end the meeting with Shanti Mantra, ma'am.
Okay, we'll end.
Shanti Mantra. Sarve bhavantu sukhinah, sarve santu niramayah, sarve bhadrani pashyantu, ma kaschit dukkhavak bhavet. Om Shanti Shanti Shanti. Thank you.
Thank you, everyone. Wishing you all the very best for your exams. I'll share the PPT. Okay.
Thank you for the session, ma'am.
Thank you.
Thank you, ma'am.